co-founder and director at Basic Healthcare Services. Previously, he worked at UNICEF's India Country program for 9 years, leading its child health program across India. Pavitra sir also extended his services in R&T Medical College in Udaipur and worked at Action Research and Training for Health, ARTH, a leading public health NGO. Sir is fellow with prestigious National Neonatology Forum of India and also recipient of Ashoka Fellowship. Pavitra sir holds MBBS and MD in Pediatrics from Delhi University and holds a Master's in Public Health from the University of North Carolina. Apart from this, he is more than what we speak, and a warm welcome to Pavitra Mohan sir. We are fortunate to have this interaction with you, sir. Thank you.
Thank you so much, Rajeshwari, and thank you, Dr. Rakam, for inviting me and to share our work at BHS with this young healthcare professionals from across the country. I am glad to be here. What I'll be sharing over the next 20 to 30 minutes is a bit of what it means for a person to receive healthcare or not to receive healthcare in a remote rural area, and what does it take to really provide healthcare in such areas with dignity, with quality, and at a cost that is affordable. We work in South Rajasthan, and our whatever I say would be relevant probably for remote, rural, and underserved communities anywhere else in the country. Can you see my screen? Yeah.
Not yet, sir.
Okay. Great. I think whenever one talks of the remote, underserved communities in the last family, I always remember this quote from Mahatma Gandhi, who said that any time that you're in a doubt and you're not able to decide what is the right thing to do, really recall the face of the poorest and the weakest person and ask that whatever you're doing, is it going to help or to be of any use to that person? And that helps you keep grounded, and that has helped us many a times when we are faced with situations on what really to do, both at a personal and at an organizational level. So I'd really urge you to keep this in mind when deciding on career, on work, or on personal lives. What does it really mean to be living in a remote rural community? So here, the areas that we work in, for example, they look like what you see on the ground. They're barren most of the year. The hamlets are scattered, and terrain is difficult. So a large proportion of the population that we work in consists of tribals. The literacy rates are extremely lower. A large number of young men and increasingly women and families also migrate to cities in search of low-paying and highly hazardous manual jobs in factories, in farms, and at construction sites. There's a low population density, which means that it is extremely difficult for people to access healthcare and also for the health services to deliver healthcare. So, people often ask us, did you work for tribal areas, or you work in migrant areas, or you work with remote communities? He said that for a person, a kind that you see a picture here, has multiple identities and also have multiple vulnerabilities. They are tribals, they're also migrants and labor migrants. The families are left behind, and therefore they have unique problems. They also are remote.
Yeah. So
hello?
Can you see screen? We cannot see the screen, sir.
Oh, you cannot see the screen.
Yeah, yes.
Just checking. Just give me a second. I'm sure. Okay. So what are you seeing on my screen, Dr. Rakam?
Nothing actually. So
Nothing.
Alvin or somebody can you guide sir how to share so that it shows here?
It's disabled the option of sharing.
No, sir, you have the option for sharing.
Yeah, I know. So I had an option for sharing, but now let me just cancel and go again. Can you see the screen now?
No, sir.
Okay. Now?
Yeah, now we can.
Yes.
Okay. Okay, we haven't lost mind. This was just the earlier slide that I was talking of the populations that we serve, and you can see that how scattered the population is, and there are one or two houses very far apart, and the terrain is difficult to negotiate, and which affects both for people to access care as well as for services to deliver healthcare. And there are multiple identities people here have. They're tribals, they're migrants, they are remote communities, they are underserved communities. So there are multiple identities and multiple vulnerabilities that one needs to deal with in such areas, and that's the reality of people living there. Coming to primary healthcare, there are a lot of misconceptions about what primary healthcare is, and therefore, rather than saying that what is primary healthcare, I would say that what is not primary healthcare. There are quite a few myths associated with primary healthcare. The first is that it will deal only with priority problems, and while since it is the first level of care, it provides a place where people seek care for a range of problems. Normally people would say that, oh, no, it is only for minor health problems or for diseases of public health importance, etc. But from the people's point of view, they would access care for a range of problems that they perceive as important. For example, we often find that a lot of people seek care in primary health care settings for skin conditions which are extremely debilitating for them, and now it's not a public health problem, but it is important for them because it affects their day-to-day living and quality of life. Um, the other myth that is often associated is that it means a standalone health post, that a sub-center is a primary health center, or a primary health center is what primary health care is, or a community health worker like A&M or an ASHA is primary health care. However, it is an integrated system. It is not one person or one institution. It is a network of health services that range from community level health provider to a facility where primary healthcare can be delivered to a secondary and a tertiary through which the person is guided. Okay, many people say, look, it's a lower level care. It is just a first level care, and then whatever you can do there. But as we'll discuss subsequently, you are faced with a range of conditions, and in absence of people having access to any other level of care, this is the best level of care at which a lot of health needs can be met in the primary care level. Finally, and which is a bit disturbing because that also deviates a lot of young healthcare professionals away from primary healthcare, is that it is low technology, non-professional care for people who cannot afford any better. While actually, the skills that are required are of extremely high order for delivering primary healthcare. It requires a team of health professionals who have not only biomedical skills of a range to manage a range of conditions, but also social skills, because you are immersed in the community and need to interact with a lot of stakeholders there, and therefore social skills are required, which are often not required at other levels of care in as much proportion. There is also, an important fact is that we can't divide people into a disease or a condition, because people have dynamic and life cycle needs. For example, this woman who came to us several years ago, some 20 kilometers away from the nearest primary health center, she presented with tuberculosis. Now, at that point of time, when she presented to us, her need was for meeting for the treatment of tuberculosis. But as she was getting better, she went on to have needs for contraception. Her children were found to be malnourished, and therefore they also needed to be managed and treated. And on the follow-up, while we were following up, she also developed Vivax malaria. So it is not at one point of time, the needs do keep on changing, and a good primary healthcare system would need to address many of these needs across the life cycle of a person and the family. There is also an important component of the needs of the family, and not only of an individual, because these needs are, you cannot have multiple sources for multiple needs of different members of the family. For example, in one of our clinics, a grandfather was detected and was being managed for diabetes. Mother or the daughter-in-law of the person visited us for medical abortion, and she was anemic and therefore needed to be managed for anemia. The child of or the grandchild was severely wasted and presented to us with an infection, and father is a migrant and lives and works in a city. So you have to manage these different conditions, which often, as I said, that there are multiple vulnerabilities and therefore multiple needs. And a good primary healthcare system would need to address a range of the needs of the family and not only of an individual alone. Now, if this setting was in a hospital, you can imagine that the grandfather might have been managed for diabetes extremely well, but nobody would have either the time or access to, in services for other needs that the family has, and ultimately the family would need to make multiple trips into multiple providers to um, get the care that they need. And in a primary healthcare setting, you need to integrate the care at the family level. So what is really, if all of that was not primary healthcare, what is primary healthcare? It includes preventive, promotive, curative, and rehabilitative care. It is often provided within or closer to the communities they serve. Um, and that's really important, because only when you are closer to the communities, you understand the various needs of the community. Only when you understand that are you able to address the needs. A hospital in a city is not able to understand where people are coming from, what are the different needs, while a primary health service located within the communities would be able to understand and deal with uh, uh, the needs that people have. So while it is offered to everyone, it is universal in nature, but it focuses on the most marginalized. And that's where, what I started with the Mahatma Gandhi's talisman is really important, because what we know, and there is a principle of what we call as a reverse equity, that whenever a service is started, it is often taken up and focuses on those who have the means, and people who are marginalized are often left behind even from a service that is closer by, because they would tend to be not able to access a health service. And therefore a good primary healthcare system, while it will offer services to everyone, would continue to focus on the most marginalized. And as I said, that it provides a person-focused and population-focused care and not a disease-focused care. For example, it would not be a program for tuberculosis alone, so to say, in the example that I gave earlier. It would be focusing on the needs of the person, which could include tuberculosis, it could include contraception, it could include treatment for malnutrition for the children. Another concept that I'd like to share with you is that we talk a lot about comprehensive primary healthcare, and a lot of emphasis is given on what comprehensive means. So what comprehensive really means, it can be thought through in two domains. One is more horizontal domain, where all the conditions, that it does not focus on one or other condition, and generally broadly the health needs are divided into communicable, non-communicable, and injuries. And a horizontal health service would address all of them at the first level of care. The second way in which we can see horizontal is a life cycle, and it's from what we call as a womb to tomb, from the beginning, from the newborn to childhood to youth and elderly. There would not be any specialized service for each of them, but these services would be integrated to address needs of people across the life cycle. And finally, horizontal also means that it offers a combination of preventive, promotive, curative, and rehabilitative. The other way to look at comprehensiveness of primary healthcare is to look a bit vertically, to say that, the primary, secondary, and tertiary. Now, the role of primary is often to also help people access secondary and tertiary care for the conditions that cannot be dealt at or the needs that cannot be met at the primary level. Oftentimes, you would see that a primary care provider or a primary health center would refer people and ask people to fend for themselves across a difficult health system, going to a hospital, reaching there. And ideally, a primary health center would have the responsibility uh, to negotiate the health system along with the patient, to assist them to access higher levels of care. There are, of course, quite a few barriers to delivering primary health care. I would not go much in detail. I'm sure many of you would probably have seen some of it yourself. Um, One is, of course, the issue of access. The areas that I'm talking of, especially the remote rural communities that I'm talking of, people often live very far from where services would be available, typically in a nearest town or in a large village, but families living in remoter areas and difficult terrains would not be able to access, and they may have to travel. So there are areas that we serve would have one bus plying in a day. And you can imagine that if somebody falls ill and there is no other means of transport, you cannot reach a health care provider when required. Absence of transport and difficult geographical areas, like I said, that there are several areas where during monsoons they will be completely cut off and it will be difficult to reach any health service. And many of the even the referral transport systems are not able to negotiate these difficult areas. The physical access is one thing. The other is that who really delivers the healthcare in such areas? There is a lot of reliance on physicians who are often non-existent. They are not either available to work in remote rural areas or have reluctance or have high levels of absenteeism. Now, the question is not so much of the numbers of doctors or physicians or um, other cadre. For example, almost 1 million new physicians, almost 10 lakh over the next 10 years. Almost every year now we're producing 100,000 new medical doctors, MBBS graduates, and they will be joining the next 10 years. There will be like 10 lakh new physicians. So the numbers is really not a problem, but inequitable distribution and reluctance and difficulty of for doctors to live and work in remote areas is really a problem. There is also in India particularly, the health system is very much built around physicians and then on specialized physicians, as opposed to many countries where there's a lot of focus on team and team of doctors, nurses, other healthcare professionals. Each of them have an important role to play. I'll speak a bit more about it later, which is really the nice way to move ahead than having an extremely physician dependent healthcare system. On the other hand, in India, you would have heard a lot about the role of ASHAs or the community volunteers and thinking that they will be panacea for everything. So there is a huge reliance on community volunteers who would have ultimately a limit in what they can do. And on the other hand, on physicians who have limited availability as well as often in many times limited skills to manage primary healthcare in difficult situations. And therefore, as I said, that most countries where there is successful primary healthcare would foster a bit of a team approach where there is a role for physician, but there are a lot of non-physician health providers and volunteers that make up for a nice primary healthcare teams. There is also, mismatch between what needs are, what people really demand, and what we offer. For example, the example that I gave earlier of skin condition, a lot of people come to us because they have been having bad skin conditions and itching for a long time. But the government, particularly the government programs, would focus a lot on public health priorities, which could be maternal health, child health, rightfully so. But at the same time, it does not match the needs of the population, which could be something else altogether. There is an interesting paradox that in the private sector, which focuses entirely on curative care, right? And the government system, which focuses a lot on preventive and promotive, but a combination really is lacking, and that leads to selective healthcare, which is a mismatch between what really people need and what is offered. There is also a lot of public and private fragmentation. A person seen by a private healthcare provider would not then be necessarily would receive support or would receive a referral from a public facility, and vice versa. So that fragmentation also affects the way people experience healthcare, especially in remote rural communities. With that background, we set up Basic Healthcare Services was set up some 9 years ago with a vision to enable marginalized and vulnerable communities that have been talking of. Such communities lead a healthy life and with dignity. For us, dignity is really important as a center of what we do. It is not that whatever you do there is enough. It is to treat people with respect and that they deserve. And still provide high quality and responsive healthcare, focusing on the last families in the communities. By responsive, I mean that really matching what people need and with the respect that they need, and that's the kind of services that we envision and we aim to deliver. To enable this, we have set up a network of primary healthcare clinics, which is called Amrit clinics in isolated communities which are remote, which have no access to other health services. Each of these clinic really is housed in partnership with the community in a premises that is handed over to BHS by the communities and the panchayats, formally. Uh, and on their invitation, we start managing a clinic, which is often managed by skilled primary care nurses who often come from similar communities that they serve. They come from rural communities, many of them are tribal themselves, and a set of community health workers who belong to the same communities. A primary care physician visits the clinics weekly and is available 24 by 7 over phone, and a small user fee is charged for the clinical services. Clinical services include outpatient management, emergency services, maternity services, basic lab tests, dispensing of drugs, provision of contraceptives. And there's also a referral service that is not, it is not just referred, but is often escorted or supported referral for both emergency and for scheduled cases that require next level of care. Uh, there's also a component of home-based care and of community-based care, which includes postnatal visits, managing patients with chronic illnesses, and following them up, providing antenatal care, health education, paying and counseling of children, and to address some of the other determinant integration with the women's groups for addressing issues like domestic violence. So if you look at that, there is a combination of it. It's based in the communities. It is managed by predominantly by nurses at the center, supported by a physician on one end and health workers on the other. It has a combination of clinic-based and community and home-based services, and a combination of preventive, promotive, and curative services. So it is closer to the definition of primary healthcare that we started with, and the aim is to keep deepening these services. People often ask us that what is it that is different, what is innovative here. So we said that really there is nothing new. It is a commonsensical approach to providing healthcare and the resources that one has to the best of his abilities. But broadly, we talk of three things: that there is a human resource kind of an innovation. Typically, a health service would be aimed to be provided by a physician, either in person or virtually. Here, what we are talking of nurse clinicians at the center, but also of a primary care team, where there's a value of a primary healthcare physician, but only in a limited manner. Then there are nurse clinicians and community volunteers that form a nice primary care team. There is a partnership innovation. We work with communities closely on one end, and with hospitals in the cities on the other end for referral care, and with other organizations that provide care, provide services such as livelihoods and nutrition to improve the impact on the ground. The third thing, which is, I think, again, a lot talked about, technology in primary healthcare and seen as a panacea. Often the problem is that a lot of technology that is developed in healthcare is actually developed for secondary and tertiary hospitals, and then it is tried to be fitted in primary healthcare with a lot of consequences. For example, the bandwidth that is required is often not available in rural areas for setting up teleconsultations, which are very fancy, but then will not work in such areas, or a management information system. So we tend to use technology that is a bit grounds up, understanding what the needs are, what the possibilities are, and using then technology to leverage those realities. For example, we often use WhatsApp video calls and or WhatsApp, taking videos and pictures and sharing it with friends and colleagues who may advise us on a radiograph or on a newborn or on a skin condition. A formal teleconsultation system would not work, but a WhatsApp integrated with some basic protocols really work beautifully. Rapid diagnostics that can provide enables quality of care. So they enable nurses, but they cannot replace or substitute. So one of the messages I would really like to leave behind is that technology in primary healthcare really enables the frontline healthcare providers, the nurses, the doctors, and the other healthcare professionals, but cannot really replace them. Rapid diagnostics are extremely helpful, and so is the energy backup for the clinics, which they're in areas where electricity would be often absent or would go off for many hours. How does that team work? So if you look at this graph carefully, there is if you look at, so one big message here is that a reasonably functioning healthcare service, primary healthcare service in a rural community would actually end up seeing a variety or managing a variety of conditions and not one or other. In this case, for example, there is a reasonable distribution among children, treatment or management of children for communicable diseases, non-communicable diseases, reproductive and child health. These are data from uh, our own clinics for a period of 3 years that we had analyzed a few years ago. So that's one big message, that a well-functioning community rooted in the community would address a range of conditions. And the second is that non-physicians have a huge role to play. As you can see, that almost in all the pies, nurses have often managed conditions much more than the doctors. And even where I say seen by doctors, the nurses have a huge role in enabling that care as well. Uh, in general, for chronic conditions, as you see, in non-communicable disease, there's a greater share of doctors, because that's where in chronic condition identifying and fine-tuning the treatment on a regular basis, there is a value of a physician there. But children, for example, for acute conditions in general, and for reproductive health conditions, there is a huge value that nurses overall add over and above the clinician. But working in tandem, they're able to address a large range of conditions in absolutely remote areas. The earlier point that I made, that when you're making a referral from a primary healthcare setting, the responsibility of the primary healthcare service does not end at the time of making a referral. You have to help the person in negotiating the entire health system, which is often quite fragmented. For example, in this case, this child presented to us several years ago with a burst abdomen. Of course, it cannot be managed by in a primary healthcare setting, but what can be done was to manage the shock, to ensure asepsis over the burst abdomen, and a scheduled and an escorted referral to the medical college hospital, where treatment was initiated, and the follow-up care after discharge was continued at the primary healthcare setting. So that's the kind of role that primary health center needs, or a primary healthcare service needs to really play. I talked of being responsive, and we progressively added conditions as we came to know. We began with more of maternal newborn child health care, but tuberculosis being an important both perceived need and an epidemiological reality of the area was what we then added. Nutrition being an important determinant of health, and we were seeing a lot of malnutrition, so we started services for addressing malnutrition. To reduce the fragmentation between private and public, and to understand what can be done in the public health facilities, there are a lot of partnerships with government in managing the primary health center of the government as a public-private partnership, and also a partnership with other organizations, the picture that you're seeing on the right, to expand the scope and the range of care in the area and populations covered. So based on some of what we've done over the last 8-9 years, there are a few thoughts that I had for young healthcare professionals, especially those who are listening today. One is that it is really exciting because you are able to address and deal with a range of conditions and needs. You interact with populations and communities and families that is not possible in a hospital setting or in a non-primary setting. So primary healthcare is really exciting, and it seems to be the only way to fix a broken healthcare system that exists currently. Because if the base is strong and you're able to manage a large number of conditions closer home at a lesser cost, that's the only way to really start fixing the system. Other levels could take care of themselves. The second message I would like to leave behind is that the teams, there is a huge value of a primary healthcare team. As I have earlier also said, there is a lot of reliance on physician in healthcare systems in India particularly. And ultimately what we've seen is that there is a huge value of primary care teams. That includes, there are things that our community volunteers can do and really interact with the communities, provide information, and which we just can't, which a physician is often unable to reach out to such large number of families. But what we often say is that while it's not really a task shifting, you're not just shifting the task to somebody else, you're really sharing it with others. So there is a task sharing within the team. It's not a physician shifting the task to a non-physician. It's that the team shares tasks among themselves to the best of whoever is the best for a job, and that coming together, it kind of gets integrated. The third is that you have to really stay grounded, immerse in the communities to understand what communities need, what would really work, and to really develop a long-term trustworthy relationships with the communities. And therefore, there is no substitute to staying grounded, to stay immersed in the communities that you're serving. There are a lot of as I said, there are multiple vulnerabilities, and you might have got a flavor of the kind of difficulties and that one has to face in delivering healthcare to such rural areas. And there is a lot of innovations that are required to address many of these issues, and therefore young minds coming to really solve these problems rather than, I see a lot of young entrepreneurs with the right intent developing one or other app, and that's really not a solution to a lot of problems that exist on the ground. And once you stay grounded and are immersed, you will understand that there are a lot of innovations that are required, which is not only about technology or only about applications, but a different way of thinking, different way of doing things that are required. And finally, it does require multidisciplinary approach. It requires different kinds of sciences and social sciences and people with different backgrounds to come together to address this extremely difficult problem of delivering good quality and low cost healthcare to the remote and vulnerable communities. I'd like to end with this quote that I really like, because ultimately healthcare is about people, and that's the most important thing. It's not about gadgets, it's not about technology, it's not about financing of healthcare, it's not about doctors or nurses. It is really about the people. And once we have this people-centeredness, that's where you will find a lot of solutions and would be committed to making a change. So I wish you all luck for anyone really willing and wanting to kind of know more or explore this whole fascinating area of primary healthcare for the vulnerable communities. We would be very happy to discuss further and and share more. So, thank you.
Thank you, Doctor, for uh, this wonderful talk. So, any participants, do you have any questions?
Good evening, sir. Uh, Sir, this is Sai Sri. Uh, Sir, as you have mentioned, there are physicians with specializations who might be reluctant to work in rural areas due to comfort problems. So, do you think virtual consultation from the primary health centers can help in such cases, sir?
So that's a good question, Sashi, that we are often talk of telemedicine and teleconsultation as a solution. So as I said, that these are things that can really enable quality of primary healthcare, but what you require at the front end is real people, doctors, nurses, healthcare providers, technicians, and pharmacists, all of them, because you ultimately healthcare is about people and about interacting with the real patients. But to enable those primary care providers at the front end who would require consultation of different kinds. So there, of course, consulting with others who are specialized in their fields is extremely helpful. For example, we often seek consultation for dermatological condition, take a picture and send it across to friends, or for an X-ray to be read. So in that sense, a remote consultation is helpful. It's not only that that a specialist is not willing and therefore it is required. In any case, there's no value of a specialized person sitting in the front. You can't have 20 specialists sitting in a rural clinic. But a strong and an empowered primary care provider at the front end is important. On top of that, a consultation with a specialized person at the other end is extremely helpful and helps in improving quality and improving care.
Understood, sir. Thank you, sir.
So, Bhaskar, do you want to ask anything? Because Bhaskar is based in Rajasthan. He's studying in one of the universities.
Mhm.
Anybody else from Rajasthan? So I have a question, doctor. So is there a way in which this family interns in their final year can be part of your team and provide some support, mostly virtually, because all of them are based on different parts. So maybe some creating a content or just talking to the patients if possible. Do you think they can fit into your team virtually and support?
Dr. Rakam, we've had interns from different disciplines who come and work with us for a period of 3 months to 6 months. So what I would really recommend is for people to really come and spend some time in the community, because without understanding that what areas and what kind of communities you're dealing with, what is the structure, it becomes extremely difficult to provide any meaningful support. But once having said that, if you spend a few weeks or enough time to just understand the area, then a remoter it is really it will be enriching and fulfilling on either sides to then maybe think of opportunities that are virtual. And as you say, that because even for content creation, you need to understand what people's
Yeah.
beliefs are, where do they live, what language do they speak. Otherwise, it can be very mismatch between what is required and what is,
Yes.
and it can be
Yeah.
frustrating on either sides. So,
Yeah. So I completely got it. So other question I have is, can we do some research because you have managed a lot of patients retrospectively or prospectively? Can we do something and publish? What do you think? Like, is there a possibility?
no, sure. And we have been trying to write and publish both in scientific journals as well as in lay press. We wrote quite a bit over the last 2 years because what we were seeing of COVID on the ground and, our own initiatives as well as the insights from the ground. So we do write and research more. And of course, there are absolutely possibilities for working together on that. Also on kind of so many times in primary healthcare setting, as I said, there are a lot of clinical protocols and are based on the needs of the hospitals. There are very few uh, primary care protocols on the ground that are based on the realities on the ground, and there we sometimes require support for researching the background of, for example, the antibiotic usage or the resistance of antibiotics in a given area, and using that input for developing protocols for the primary. So those are also areas where one could potentially could be extremely helpful to work together, and the inputs of PharmD students and professionals could be very useful.
Yes. Well, I will share this video with few of the people I know who might help in this part also, the other part which you mentioned. So any other students have a question, or if not, any feedback? Does anybody want to share feedback? So Satyasri, we are not able to hear it. Like, looks like you have unmuted, but so we have good number of people from Gujarat also here. So anybody wants to share your feedback before we end?
Hello, sir. This is Sai Sri. Sir, I would like to give my feedback. Sir, thank you so much for spending your precious time to address us. So, as you said, there are many myths about primary healthcare, and we generally ignore the facts. And whenever I listen to something noble and inspiring, I get very inspired. And your vision and mission were extremely noble, sir. Thank you so much for explaining these things to us, sir.
So doctor, I'll collect the feedbacks and send it on WhatsApp. We already have few in the chat box. So it was very inspiring. Actually, most of us, though now we live in cities, we have our roots in villages like the places you are serving. It gives us inspiration to give something back to places where we were born and spend our early days. And I'll keep in touch with you and see if we can provide some opportunity for these people to learn and do some research and also the protocol part. So Thank you so much, doctor, for taking your time. It was a pleasure
Sure.
listening to you.
Same here, absolutely my pleasure, and it was wonderful speaking to this young professionals, and I'm glad that many of them would probably aspire to work in the area of primary healthcare, and we're very happy to stay connected and support in whichever way.
Sure, doctor. Yeah,
Bye.
so we can end. So bye and take care.
Bye.
Thanks
Thank you.
everybody for joining.
Thanks.
Bye.
Thanks.